Hi, welcome to the Pro Sport Academy. Today's blog post is all about the ankle mobility test.
Okay, so we're going to talk about the ankle mobility test, okay, or the lunge test as it's referred to in the literature. Now this test is used a lot by a lot of strength and conditioning coaches and a lot of physios. Now what we're going to do today is we're going to dissect that test a little bit. As with all Pro Sport Academy therapists and coaches, we want a fundamental understanding of everything that we're doing. We want to know exactly why we're doing it and not just doing something for the sake of it. Okay, that's very, very important that we understand it all. Now, I get a lot of students in the professional sport setting with us, and they're very, very good at doing their tests, but they don't actually know what's going on in those tests or why they're doing those tests. Okay, so what we're going to do with the ankle mobility test today is explain what we're looking for, and most importantly, if there is an issue, how to fix it. Okay, because there's no point doing the test if you don't know how to fix it. Okay, you might as well spend your time working on stuff that you can influence. Okay, so the lunge test, as it's referred to in the literature, is you keep the heel on the floor, toes pointed straight ahead, and we're just going to bring the knee over around the second toe. Okay, you're going to get the distance from the tip of the big toe to the wall. Just make sure there's no skirting board on the wall there either, okay, that you're getting it straight to the wall. Okay, you're going to go back as far as you can, and you're going to get that knee to touch the wall without the heel lifting. Okay, a lot of people are suggesting 10 centimeters or greater. Okay, 4 inches ideally that we need. Okay, and the literature is a little bit vague in the normative data. Okay, but what it is suggestive is if we lose our ankle range, that is a predictor of injury. Okay, so there is some literature out there to support that notion. Now, a lot of athletes will do this day in, day out. It's a very, very cheap test to do. You can use a ruler here. A lot of clubs will have their homemade devices made where they'll just have a piece of material with the increments. Worst case scenario, print out a sheet of paper with known increments of, I usually do in centimeters. Okay, or if you're really stuck, get a bit of zinc oxide tape, get your ruler in 1 centimeters, draw it on. Okay, pop it down on the floor. Works really well when you're traveling away with clubs and you're in hotels, or if you're training at alternative venues. Okay, it's very, very easy to do. So now that we've done the test and we know that there's a restriction in the range of motion, now what? Okay, this is very important that we can make a big difference straight away with this test. If an athlete comes into us and they're down on this, okay, we need to get it up straight away, and there's a couple, probably 3 or 4 potential issues or causes of the reduced range of motion. Okay, so if we bring the knee to the wall again, and the athlete reports that there's a blockage, or what's stopping them going further, that's the question I'll usually go, is what's stopping you going further without the heel coming off? And they'll usually either report it's a blockage in the front of the ankle joint or the tissues at the back. Okay, so let's cover the front of the ankle joint first. So the front of the ankle joint issue, this is usually indicative of a joint issue, as I was just saying there. Usually what's happening there is as the tib and fib come over the talus, okay, as Dave's doing here, that talus needs to come back into the mortise, okay? Now that needs to slide back slightly. Now when that slides back, the ligaments at the back of the talus need to lengthen, okay? So these ligaments here at the very, very back, called the talofibular ligament, okay, and the tibio-talar ligament, okay, they need to lengthen in order to allow that talus to jump back, okay? You see a lot of therapists, they'll do mulligans where they give that AP, okay, they'll stick their fingers in here, or a lot of S&C coaches will prescribe it where they're putting the band here, okay? You've got your power bands, so the pressure will be coming from here and they're giving it that AP. What's happening, in my opinion, there is as the talus is coming back, they're stretching that ligament. Now a lot of athletes, that would work okay, but then they'll come in the next day again and the restriction and the loss of range of motion is still present. Okay, so they get what's called a reflexive change, in that your nervous system adapts temporarily, but it doesn't treat the true cause. Okay, so from my experience, a lot of it can be that the ligaments themselves have adhesions, okay, or they've got issues lengthening. Okay, so we can get in with some very specific hands-on techniques there, which all the Pro Sports Academy therapists are trained in. Okay, so Just be aware that if it is an issue in the front of the ankle joint, more than likely the structures that need the specific treatment, okay, will be at the back. Okay, the talofibula ligament and the tibio-talar ligament. Quite a mouthful there. Okay, so we can treat those. The mulligans are absolutely fine as well. If you're really good at those, they will cause a change in it as well, in that they'll allow that talus to jump back into the socket and the tib fib will come over nicely. Okay, so that's the first one usually, okay, if the issue is in the front of the ankle joint. If it's in the back and they report, oh, I feel it's tight in my calf, okay, or Achilles, then usually what we're not suspecting is the gastro muscle, okay, so that outer layer of the calf, that's not going to be on full tension because the knee is flexing, okay, and that's very, very important, okay, and a misconception, a lot of people, they'll give that straight leg calf stretch to correct this. That's not going to do anything for this because the calf here, okay, it's on stretch at the distal end, but it's taken off stretch at the proximal end. So the gastro will certainly won't be a priority for us. What will be a priority is the soleus, okay, so that deeper calf muscle, okay. So as that knee goes forward, okay, that soleus is required to lengthen, okay. So that would be one that usually we'd see a lot of adhesions in, okay. Also the soleus can take up the slack for a lot of athletes, in my opinion. So this test alone, we would need to cross-reference it with another test, okay? So why is that soleus? Now that's the next question. Why is that soleus getting tight? Why is it overworking? Okay? It's a very, very important function of that in the knee as well, which is beyond the scope of this blog post, and that's another edition. But that soleus takes care of the knee also. So if something's not happening at the knee, okay, or something's not happening at the hip, so if we've decreased hip extension, potentially we've got an early heel lift, that soleus will be required to work that a little bit harder, okay? So then we want to be thinking, okay, well, if we release the soleus, what else do we have to make up to take up the slack, okay? So if we just keep releasing soleus and it keeps tightening, then potentially there is another issue in the body. Potentially the glutes, potentially the hamstrings, who knows? It's very, very specific to every athlete, okay? And that's what we need to be aware. There's no cookbook stuff here, unfortunately. Every athlete's different. And the stuff we see on a daily basis in real life, okay, everybody is different. We can't just assume, okay? That's why we need this foundation, this key understanding of our anatomy, okay, among other things, motor control, etc. Okay, so the soleus, that's another one, okay? Possibly also, we can have a look at the deeper calf muscles also, your flexor hallucis. So if you have a stiff big toe, potentially that mightn't be lengthening either. Now that muscle is quite an interesting muscle because as your knee goes forward, it starts on the outside, okay, of the tibia and it juts through under the Achilles tendon itself, okay. So if that doesn't slide well as that knee's coming forward, it can just adhere a little bit to the Achilles tendon, okay, because it juts under it. The fascia can get a little bit bogged down there. So that's why a lot of athletes will feel like it's their actual Achilles is the problem, but very often it's actually under the Achilles and it's the flexor hallucis longus, okay? There's a very, very easy way to differentiate with those as well, which we go into in the mentorship, and it's very, very simple. So as we come through, other ones, tib post, possibly as well, and also the flexors for the toes, the digitorum. Flexor digitorum longus. Okay, so all those will be going into your list. How are you going to find this? Well, the easiest way is to palpate. Okay, palpate the tissues, see what you're feeling. Is there a difference in your tissues left and in right? Cross-reference these tests with other tests, such as hip extension tests that you have, versus knee tests, versus whatever else you do. Okay, this is only one test. It's not going to give you the whole picture, but it can give you a big piece of the puzzle into what the structure that's causing the reduction is, and then from there we need to take that information and go one step further and ask ourselves, why is it getting tight? Okay, very often if it's pre-season training, your soleus is working hard because you're doing a lot of running, okay, but if it's consistently getting tight, then we need to ask ourselves, what is it overworking for potentially? And that's where we need to look at other stuff. Okay, so that's just a quick snapshot of the ankle mobility test. I hope now you can actually understand a little bit more in depth about what actual structures are required to lengthen here. If it is down, what structures are potentially causing it. among other things. Okay, they're the two big culprits. We'll go into a couple more in a second, but if you can get those two right and be comfortable with assessing those two structures, then you're going to be doing really well. Okay, so in this final piece, a couple of other issues where if you've taken care of the distal ligaments around the talus, and we've also looked at the soleus and the deeper calf muscles, we've treated those, we're happy with the tissue quality there, that we don't need to do any more hands-on treatment. There's also a couple of other places that can be commonly bogged down. Okay, now the soleus itself, okay, actually attaches into the proximal hip fib joint. Now this is also a part of the issue, which is why the soleus is so important. So as that knee comes forward, okay, the soleus has to lengthen. That hip fib joint is going to travel forward as the distal travels back, okay? And again, we've all seen this with the mulligans, and that's no big deal. But now you can actually see why the structures, the actual muscles need to lengthen in order for those joints to be able to travel and slide and glide as well. Now, very often, if that hip fib can't travel back, as I said, that proximal hip fib won't come forward, and then that won't encourage that internal rotation, okay, that needs to happen. So the tib and fib actually are going to slide inwards ever so slightly. Now, I'm not talking about inside the big toe, but there is a transverse plane motion happening at the tib fib. So that needs to come forward and also twist inwards, okay? Now, if we look at other ligaments, so we're going to have a look at the calcaneus. The calcaneus is going to evert as this motion happens. So as that proximal hip fib comes forward, the distal comes back, the calcaneus is going to evert. There's the deltoid ligaments on the inside of the ankle. They also can get bogged down sometimes, okay? They can get a little bit gluey, and they might need a little bit of work as well. So you can use your instrument assisted stuff, you can use hands-on stuff if you're trained with that, or just general massage works quite well as well. Okay, so assess this motion if you've cleaned up everything else and it's still a bit sticky. Okay, so that internal rotation of the tib fib, which is then going to drive a little bit more internal rotation of the femur, okay? And if you've had an issue with a knee, okay, so this is where your individualization of your players and your athletes are so important, okay? If you've cleaned up all this, but you know that the athlete's got an issue with their knee, for instance, you know, it could even be a meniscal issue where the popliteus then could become involved. If this knee isn't moving very well, then that has a big effect on what's happening at the ankle as well. So just be aware of that. Okay, also be aware of bone spurs, okay, if there's a blockage in the front of the ankle. But then again, I would say, well, actually, why did that bone spur happen in the first place? It was because that talus isn't dropping, and over time, you start to develop those little issues there, okay? So we always want to go one step further, ask why these things happen, okay? So the knee also will be potentially one. And then finally, if you want to go further up the chain, the anterior glute med is another one, okay? So the anterior glute med needs to control concentrically, okay, that internal rotation happening at the hip. If that femur's not twisting in well, okay, and the tib fib's not twisting in well, then sometimes that talus might jam as well, okay? So there are other options that you might want to look at if everything you've cleared here and you're still getting issues, okay? So, you know, an injury here or an injury here previously might be big clues, okay? So, as always, please, one size doesn't fit all, unfortunately. Every athlete's different. They've all had different injury histories, and as we know from the literature that the previous injury is a big indicator, okay, so predictive of injuries. So I hope that was helpful. As I said, a lot of people are using this test, and now I hope you've a bit more of an insight into the structures that you're actually challenging and what potential issues that there will be. And I look forward to seeing you next time.